Okay, so I think we can get started. Hello, everyone. Welcome to the Healthcare AI Forum. I'm Yuan, host of the forum. And for today's session, I'm happy to introduce Benjamin Burns, who is going to talk to us about flexible and robust fusion of clinical imaging modalities. So Ben is a NSF Graduate Research Fellow, University Fellow, and Computer Science and Engineering PhD student in Dr. Ning Xia's group at the Ohio State University. So his research explores novel deep learning methodologies for focusing on the fusion of these disparate clinical modalities and supporting clinical decision making. And he has an emphasis on applications to Alzheimer's disease. So he has published several papers in peer-reviewed venues, including iClear, EMNLP, NPJ Precision Oncology, and Ben graduated from the Ohio State University in 2025 with a bachelor's degree in data analytics, and where he was a Stamps Eminence Scholar, which is one of the university's most prestigious merit-based scholarships. So now, without much further ado, I'm going to turn the stage to Ben.
Thank you for that introduction. Hello, everyone. Unfortunately, my PI, Xia Ning, could not be here today, but I'm happy to be representing Ning Lab today. I'm a first-year PhD student in her lab, and I'm going to share a little bit about our recent work on flexible and robust fusion of medical imaging modalities. And to give a high-level overview of the structure of the presentation, I'm going to begin by talking about the opportunities and challenges in multimodal AI, why we're interested in developing multimodal medical AI systems, and the challenges that make developing these systems highly non-trivial. And then to demonstrate some of these challenges and our attempts at addressing them, I'll explore two of our recent publications. The first dealing with flexible fusion with missing modalities, and the application here is predicting Alzheimer's disease progression. And the second paper deals with robust fusion with heterogeneous modalities, and the application here is to cardiopulmonary disease prediction in emergency care settings. So let's get right into it and start by discussing some of these opportunities and challenges. And in the process of introducing the motivation for multimodal AI and these challenges, I'll introduce the background for these two papers. The first one being Alzheimer's disease. And I'm sure that most of you, if not all, are aware of Alzheimer's disease. But at least I was surprised to learn the very high prevalence of the disease is a lot higher than I expected, and the impact is extraordinary. If you don't know what Alzheimer's disease is, it's a slow, progressive neurodegenerative disease that over time results in a loss of cognitive function and eventual cognitive impairment as well. And surprisingly, 1 in 9 adults in the US over the age of 65 have Alzheimer's disease, and it's estimated to cause 100,000 deaths annually and over $300 billion in annual care costs in the United States. So there's not only a very high health burden related to Alzheimer's disease, but there's also a very large economic burden as well. And unfortunately, there's no currently known cure for Alzheimer's disease. So for all of these reasons, it's imperative that we develop methods to better understand Alzheimer's disease and its progression. And speaking of Alzheimer's disease progression, it varies widely from patient to patient. Looking at patients with mild cognitive impairment, some will progress very slowly from mild cognitive impairment to dementia over a several year period, whereas others can have the same level of cognitive decline over a much shorter time period. And for this reason, we want to develop methods to predict this Alzheimer's disease progression rate so that clinicians, physicians can provide more individualized management to their patients based on the predicted rate of progression. And we measure Alzheimer's disease progression using a change in a metric that evaluates the level of cognitive and functional impairment called CDR-SB. This stands for Clinical Dementia Rating Sum of Boxes. And this scales from 0 to 18, with 0 being the normal cognition value, and 18 being the most severe level of impairment. We're specifically interested in looking at the change in this metric over a 12-month, 1-year period. And within this, we're also specifically interested in patients with initial cognitive impairment levels associated with mild cognitive impairment. So this would be about 0.5 or 1 to 2. So looking at the distribution of the change in CDR of these specific patients over a 12-month period. Blue and yellow curves here, and we can see that there's quite high variance in this distribution, with on average the changes being quite small, close to zero, but there's some patients that have very large changes, very large increases in cognitive impairment over the period, and some that even experience regression in their symptoms and actually have improved cognition over that 12-month period. So it's a very non-trivial problem to perform this type of prediction. And in order to develop systems to make these Alzheimer's disease related predictions, we need to have some basic understanding of the mechanisms, the biology underlying Alzheimer's disease. And it's a very multifaceted disease manifesting in several different ways. For example, it can appear as gray matter atrophy, where we can see physical shrinking of the brain due to mass neuronal death. And it's believed that the key drivers of this death include two protein aggregations, amyloid beta plaques, which are these yellow spherical clusters in the image to the right, and tau tangles, which are the blue clusters inside of the neuron cells. And if we want to obtain a holistic view of a patient's current condition concerning Alzheimer's disease, then we need to have a way of accounting for each of these distinct signatures. And fortunately, multimodal neuroimaging allows us to gain these different views. Specifically, T1 MRI and FLAIR, a different type of MRI weighting contrast, highlight structural changes in the brain, and we can see that atrophy in the gray matter tissues. That would be this grayscale image in the top left as an example. And we can also use PET with different radio tracers to detect the presence of amyloid beta and tau protein in the brain. And that would be an example, the sort of more colorful heat map-like image in the bottom right. Each of these modalities provides a complementary view of Alzheimer's disease that, when taken together, can give us a more holistic, clearer picture of the patient's current condition. So accordingly, predictive methods that perform very well at Alzheimer's disease prediction will incorporate multiple of these neuroimaging modalities. The challenge arises when we're in the case where not all of the modalities are available. In this example here, say the PET scan is no longer available. In a system that's developed to incorporate both MRI and PET information, how do we make the prediction when PET is not available? Now, quickly jumping to our other application, cardiopulmonary disease prediction, here we're addressing a different challenge and a different background. And specifically, we're trying to differentiate between congestive heart failure, coronary artery disease, and COPD and related pulmonary diseases in emergency care settings. And we care about this problem because all these diseases can present similarly in emergency care settings because they have overlapping symptoms, including shortness of breath and chest pain. And studies have found that some of these diseases, COPD and heart failure, are often prone to mutual misdiagnosis. And in the ER, these misdiagnoses not only risk inappropriate therapy, but it can also run the chance of compromising patient outcomes. So we obviously want to avoid this and need to develop systems to better distinguish between these very related diseases. And the modalities that we're interested in here are not just neuroimaging, we have some non-neuroimaging modalities as well. We're looking at ECG, electrocardiogram, and CXR, chest X-ray. And ECG, depicted in the top left, pink here, is primarily used to assess cardiac conditions, of course, but it can also reflect certain pulmonary pathologies. And conversely, chest X-rays are typically used to evaluate pulmonary abnormalities, but have also been shown to reveal some structural indicators of cardiac disease. So there are some similarities or some comparisons we can make between these two otherwise very different modalities. But unlike when we were dealing with multimodal neuroimaging, where all of the sources of information were in the same image spatial domain, these two sources of information here, these two modalities, are inherently different in both structure and semantically different as well. One of them is time series temporal data, the other is spatial image data, and they describe very different physiological processes. So the challenge here becomes how do we effectively align these modalities so that our model can take advantage of learning the relationships between them in order to make a good prediction. So now that we've covered the motivation for why we want to develop multimodal AI and the challenges that we face in doing so, we can start getting into the specifics of our attempts to address these challenges. And I'll start with flexible fusion with missing modalities. And as a reminder, this is dealing with Alzheimer's disease progression prediction, specifically predicting the change in CDR-SB for patients with mild cognitive impairment over a 12-month, 1-year period. And we derive these data points for training and evaluation from longitudinal clinical study data that resembles more or less the diagram in the bottom of this slide, where for each patient, they have regular visits at regular frequency, say every 6 months. And at each of these visits, they can have some modalities and information collected. So for example, at 12 months, the patient can have their CDR measured as well as a couple of neuroimaging modalities, not necessarily the full breadth of all of the neuroimaging that is possible to take. And a year later, 12 months later, they can also get a follow-up appointment where they have their CDR reevaluated. So we can measure the difference in the CDR over this 12-month period and try to use the neuroimaging modalities available at the 12-month checkpoint to predict the CDR 12 months later. And to understand why missing modalities pose such an interesting issue for multimodal systems, we have to look at how multimodal fusion is typically done. And this is a very basic generic example where we have our raw image input modalities, and we learn with deep neural networks feature extractors to extract dense representations from these raw images. And the representations that are extracted from these images are then fed into a fusion module, which learns how to combine these two representations into a single unified patient level representation that we can use to with a classifier to perform a prediction. The issue here is if we no longer have one of the modalities that the system was designed around, the fusion module is expecting to receive both of these extracted features as input, but if it doesn't have those available, then it can't actually operate, and everything downstream, including our classifier and prediction, cannot be performed. Now, the obvious and maybe naive approach to fix this is to pretend that we have that missing data. We can use imputation methods, such as a generative model, to use the information we do have to guess what the PET image would look like. And that's what I try to represent with the purple down here. And then we can proceed more or less as normal with our fusion module, the classifier, and prediction. However, there's some very obvious issues with this naive approach. The prediction is obviously going to be very sensitive to the quality of the imputation. And if we're using a generative model to get our imputations in the feature space, it can be very expensive, both in terms of training, but also the amount of data that's needed to train an adequate generative model. And the more concerning issue is that the fusion module operates the same on the real versus imputed features. It doesn't know what is real or imputed, and the processing proceeds the exact same way, regardless of whether or not the information being fed to it is reliable. Intuitively, we would like to have differential processing, the flexibility to process inputs based on which ones are actually observed and which ones may be imputed and may be unreliably imputed. So for these reasons, this simple imputation technique, which is the most prevalent approach is what I would call an unreliable quick fix, more or less a band-aid slapped onto the issue without addressing the underlying problem. So what can we do? Well, there are some other methods like FlexMOE, for example, which aim to provide that additional flexibility. So no longer a one-size-fits-all approach where the data is being processed identically regardless of whether it's real or actually observed or imputed. And uh, the key idea behind this method, which I mentioned because my method is very inspired by FlexMOE, is captured in this bottom right panel. It's a very complicated diagram with a lot going on, but I'll ask you to only focus on the bottom right panel D, where the key technology in this method is the mixture of experts and how they specialize the experts in this mixture of experts in order to correspond semantically to different modality combinations. So in this way, every single modality combination has a dedicated expert in this mixture of experts layer to process the inputs. So no longer having the one pathway through, we have branched conditional pathing. And I'll explain the FlexMOE a little bit more in depth so that we're on the same page, since this is key to both the FlexMOE method and my method. So a mixture of experts is really not that complicated. First, I'll start by describing what a traditional feed-forward neural network would resemble. It's a fixed sequence of transformations where an input follows through this fixed pipeline sequence of transformations, and it's always this one route. The mixture of experts allows us to change some of these layers to be branched in a sense, and this branching is conditional based on the input. So each of these experts here, usually a very simple neural network, an NLP, and our input first passes through a gating network, or more often referred to as a router, which determines which experts to activate based on that input. And then the output of the mixture of experts layer is more or less a weighted average of the activated experts' outputs. So in this way, the router and the experts can work in tandem to learn specialized pathways for different types of inputs. So inputs of type A, for example, may begin to be routed to expert one more frequently, and expert one can become specialized in processing that type of input, so to speak, expert in that type of input. The idea behind FlexMOE is to use this mixture of experts model in order to have the experts specifically specialize in processing the different combinations of modalities. So for an example, in the bottom right, we have an input where we have the green, yellow, and red modalities available, but we're missing the blue modality. And there is a router, or there is an expert in this mixture of experts that the router maps the input to that's specifically designed to handle inputs of this modality combination. Or in another example, we have just the blue modality available. There is a different expert intended for just that blue modality. So this is the key behind the FlexMOE method. And although it works pretty well in cases where we have occasional missingness of modalities, say if we have 4 modalities at most, when there's 3 modalities available, it works pretty well. It handles that case of missingness decently. However, in the case where we have extremely limited modality availability, just 1 or 2 available, then the performance degradation is still quite severe. And this is problematic for our application where we're using multimodal neuroimaging, where it's more often than not going to be the case for patients with MCI, mild cognitive impairment, to have very limited modality availability, very few neuroimaging scans available. So we'd like to build a model that focuses on explicitly bolstering performance in this case where we have extremely limited modality availability, while still being able to incorporate additional modalities if they are available. So with that background, I'll introduce my method here, which is very similar to FlexMOE with one key modification in the router. So my method is called PERM-MOE, which stands for per modality mixture of experts. And the key idea here is to replace what in FlexMOE was a single generalist router of sorts that had to route every single modality through the mixture of experts. We now allow the model the additional flexibility of having independent routers for each modality. So to sort of correspond this back to that original block diagram we saw for the conventional way of processing or designing a multimodal system, we have the modality independent coders here, where each of these serves as a feature extractor that's learned. And then our module or modality fusion module is two parts. We have initially a self-attention layer. This is the same as FlexMOE. And then this is followed by the mixture of experts. And again, the change here is that now each modality is able to be routed through the mixture of experts independently by its own router specialized for that modality. The intuition here is that when we have just one modality available, we would like to rely or be able to use a router that is customized for that one modality we have available, rather than having to rely on the generalist router that must cater to every single modality. In this way, when we have just the one modality available, we have a routing strategy that is optimal for that one modality. If we were just using the generalist router, the experts that are activated may not necessarily be the best ones. Now, to train and evaluate our method, we use the Alzheimer's Disease Neuroimaging Initiative dataset, often abbreviated as ADNI. This is a longitudinal Alzheimer's disease dataset tracking hundreds, probably thousands now, of patients over a long period of time with regular visits where they obtain various neuroimaging, lab exams, different procedures. And from this data set, we derive 837 subjects across about 470 unique participants. And notably, the modality availability among these participants or among the subjects varies quite a bit. And this distribution of modality availability is displayed in the Venn diagram on the right here. Of the four modalities that we were using, the MRIs and the two types of PET, only 49 of the 800 something patients have all four available. The vast majority of the subjects have just one or two modalities available, particularly T1 MRI and amyloid beta PET appearing to be the most prevalent in the dataset. The PET images, fortunately for us, are already pre-processed by ADNI, but the MRI are not pre-processed, so we develop our own pretty standard MRI pre-processing pipeline. We start from the initial images, the raw data in A in the figure, and we first register to a standard template so that the different anatomical structures in the brain are aligned consistently within the image. And then we strip away all non-brain tissue to just get the brain. And finally, we apply some corrections, including N4 bias field correction, to get our final image that is input to the model. We evaluate the performance of our method on predicting 1-year change in CDR sum of boxes for patients with mild cognitive impairment. And we compare these results with FlexMOE, which at the time was the state of the art in this type of problem. And in the case where we have only one modality available, we also compare our performance to that of the respective unimodal model. Now, the way to read this table is the columns correspond to different modality combinations of the data we're evaluating on. The circles indicate the presence of a modality, and the empty ones indicate the absence of a modality. M stands for T1 MRI, F for FLAIR, A for amyloid beta PET, and T for tau PET. So the columns all the way down at the left side here corresponds to the cases where we have just one modality available, and these are the ones we're most interested in. And the ones all the way down on the right correspond to the cases where we have all or very many of the modalities available. So again, we're interested in the case specifically where we have very limited modality availability, as this is the expected case in a realistic clinical scenario. And we see that our method, PermMOE, outperforms FlexMOE on every single one of these cases for all cases where we have just one modality available. And further, when we have additional modalities available, our method remains competitive with FlexMOE. And I'll mention that the metrics we're looking at here in each of the cells is the root mean square error. So the lower this value is, the lower the error of our predictive method on average. And finally, I want to look at some of the under the hood of the method and try to understand where these performance gains are coming from. This is a very complicated diagram, so I'll break it down and then pull out two key highlights from it. First, it's separated into two sections. The left side describes FlexMOE, the baseline we're comparing to. The right side describes our method, PermMOE. Each column here represents an expert in the mixture of experts layer, and the index at the bottom of each column indicates the intended modality combination of each of these experts, and that is given in the key to the right. So for example, the first column in the FlexMOE diagram, 8, is the expert that's intended to process inputs that have FLAIR and amyloid beta PET available. Now, the dots above each of these columns indicates the relative frequency of activation of each of these experts, where a larger dot indicates more frequent activation of an expert, and a smaller dot indicates less frequent. And finally, the different colored segments of each of these columns indicates the distribution of the modality combinations that are being passed as input to these experts. So the colors and the numbers inside each of the segments in the key indicates what type of input is being passed. So again, using this first column, first expert, as an example in FlexMOE, over 50% of the inputs that are being routed to this expert corresponds to the combination 11, where that is just T1 MRI available. So some of the observations to pull out of this diagram is there's a lot going on. First of all, I'll highlight that our method appears to have more balanced activation of the mixture of the experts in the mixture of experts layer, whereas in FlexMOE, a lot of these dots, so there's more variance in the size of the dots. In our method, the dot size is more consistent and usually quite large. This is a desirable property, indicating that our method is not letting any of the power of the mixture of experts go to waste. We ideally want to see that every expert is being used to some extent. If some are not being used very frequently, then that poses a big issue. It means we're losing out on some of that power. And also, I'll note that our method appears to, on average, have a more diverse distribution of inputs being routed to each of the experts. We can see this by the higher entropy of the experts in our method compared to the FlexMOE method. And still, even though we have a more diverse range of inputs being routed to each expert, we still do maintain some degree of that modality combination specialization that's conditioned. I think that this is a good thing because it may indicate that our experts are learning to specialize in ways beyond simply the modality combination. There could be some less obvious ways that the experts could specialize that further improves performance that our method may be taking advantage of, whereas FlexMOE may not. So now moving on to the second paper, which I'll discuss at a much higher level. It's a more technically involved paper, but I'll pull out only the key fundamental ideas here. As a reminder, the challenge we're trying to address here is robustly fusing heterogeneous modalities that are very semantically and structurally different. So here we're now assuming that all of the modalities are available. And the application is for differentiating cardiac disease from pulmonary disease in emergency care settings. The modalities that we're using here are the ECG, chest X-ray, and EHR clinical parameters. And unlike when we were using the neuroimaging modalities, where all of the channels of information were very similar to each other by virtue of all being a form of imaging and all being focused on the brain, these modalities are different in many ways. For example, the chest X-ray and ECG are analyzing different physiological processes and are also structurally different. One is an image and one is time series data. And further, the EHR clinical parameters, electronic health record, are also fundamentally different from these other modalities. The EHR data is inherently more high level and abstract. It's a high level summary of a patient's condition, whereas these two other modalities are low level physiological signals where the information is very dense but not immediately informative, whereas in EHR, the information is sparse but very semantically rich. So being able to train a model to take advantage of and learn the relationships between these modalities can be challenging, more challenging in the case that we have all imaging modalities. And the way that we try to uh, develop a model that can take advantage of the relationships between these modalities is what we call dual domain hyperbolic fusion. And this is another very complicated diagram. So I'm going to pull out what I believe are the key ideas behind our method. The first one being using the frequency domain to fuse and learn the relationships between chest X-ray and ECG features. And the second idea is using a hyperbolic embedding space in order to learn how to fuse clinical parameters with the lower level physiological signal data from chest X-ray and ECG. So let's start with the frequency domain. Uh, and to motivate why we're using the frequency domain, we have to understand that both of these modalities, ECG and CXR, capture physiological rhythms associated with cardiopulmonary activity. So it makes sense to analyze the rhythms and the frequencies in the frequency domain. Specifically, respiratory cycles are captured obviously through periodic diaphragm movement, which may appear in chest X-ray, but it can also appear as baseline fluctuations in ECG signals. So this underlying process is captured in the frequency domain in both modalities. Similarly, cardiac rhythms will obviously appear on ECG, but they can also show up in chest X-rays through vascular pulsations. So by analyzing these modalities in the frequency domain, uh, they all of a sudden have these much stronger and more rich interactions and relationships that were less obvious when we were just looking at them in the spatial and temporal domains. So the fundamental idea here is that by projecting these modalities into the frequency domain, we can learn a frequency fusion module where the interactions between the modalities are more clear and immediate in order to learn better the relationship between the modalities. The second key idea is using a hyperbolic embedding space in order to fuse the high-level clinical parameters with the more low-level chest X-ray and ECG information. And this one is a little bit harder to explain in a general way. But the key idea here is that these high-level clinical parameters, they're indicators that we may observe supporting evidence through the low-level physiological signals captured in the ECG and CXR data. But the clinical indicators, the electronic health record, is a more abstracted version of these data. And this creates an inherent hierarchical relationship between the EHR and the low-level ECG and CXR data. This hierarchical relationship, if we try to force the embeddings to exist in a Euclidean embedding space, could result in some suboptimal performance because the hierarchical relationships can't be naturally captured in that embedding space. But we can make use of hyperbolic geometry, a manifold with constant negative curvature, which inherently allows us to very easily represent hierarchical relationships. Um, a way to maybe understand this is to view the hierarchical relationships as a tree-like structure, where if we are able to embed these in a hyperbolic embedding space, where the representational capacity in a way expands exponentially as we move out from the origin, we can represent these sparse and very abstract feature representations for the EHR close to the root of this tree near the origin of the hyperbola, and the more low-level signals, which are the supporters uh, for this high-level abstraction, can be expressed more towards the edge of the hyperbola, and that's how we inherently capture the hierarchical structure. So these two ideas are the key drivers behind our method, dual domain hyperbolic fusion. In addition to using the frequency domain, we also learn ways to interact between the original spatial temporal domains and the frequency domain, so that we're making use of the original unprojected modalities as well. There are also a few other very interesting contributions, such as our novel hyperbolic cross-attention and soft entailment loss, which condition the hierarchical relationship in the embedding space. But I won't be going into the details of those today. If you are interested, I highly encourage you to check out the paper. And to train and evaluate our method here, we use the Mimic4 dataset along with some extensions which provide us with additional data about the patients in that dataset. And all of those are listed here. In total, we collect about 40,000 subjects across 26,000 unique patients. So a very large data set that we're able to obtain here. And the task we are performing is multi-label binary classification, where each of these labels that we could be predicting are congestive heart failure, coronary artery disease, and COPD, along with related pulmonary conditions, kind of a lump category at the end here. And this is multi-label binary classification because a patient could have both of these diseases simultaneously. So it's not a one versus rest. It could be a patient has one, two, and not three. And to evaluate our method, we compare against several baselines on both the setting where we're using just ECG and CXR, but also the setting where we're using those low-level modalities along with the high-level electronic health record data. And this is comparing against another set of baselines. In both of these settings, looking at the micro AUC, we see that our method outperforms these baselines by a large margin, and this ends up being a significant margin as well. And we want to look at the key components that we added, because there's a lot of moving pieces in the method. We want to make sure that each of these design decisions was justified and contributes meaningfully to improved predictive performance. So we do this through an ablation study. And first, we look at removing the frequency domain. So cutting out projection to the frequency domain and the frequency fusion module, just using the native spatial and temporal domains. And we see that by losing out on this frequency domain, we actually do experience quite a severe drop in predictive performance from 0.818 in micro-AUC all the way down to 0.792. So clearly there is something being learned by comparing these modalities in the frequency domain that we can't do with just the spatial and temporal domains alone. But conversely, if we just use the frequency domain and get rid of the spatial and temporal modalities or domains, then we also experience quite a severe drop in performance, an even larger one, in fact. So neither of these domains in isolation are sufficient for addressing this problem with high predictive performance. We actually need to use these in combination, in tandem. And the other key idea behind our method, the hyperbolic embedding space, if we get rid of that and just use Euclidean embedding space, we also see quite a large drop in performance. And this is likely due to not being able to richly express those hierarchical relationships between the clinical parameters and the low-level modalities in simple Euclidean geometry. So to conclude and provide some key takeaways, we've seen that, of course, we need to incorporate multimodal information in order to develop very reliable, very strong clinical prediction systems, because diseases are inherently multifaceted, and a single modality alone is rarely enough to capture all of the complexities of the disease. We've seen that in the case where we have missing modalities, we can use per modality routing in a mixture of experts type model in order to become more robust to this missingness in the case that we expect to have severely limited modality availability. And in the case of cardiopulmonary disease prediction, where we're dealing with very semantically and structurally different modalities, we've found that by creatively using the frequency domain, we can more or less bridge the gap between these very disparate modalities and allow the model to more easily learn the relationships between them. And finally, we've also found that when the modalities are different in the sense of information density and there's a hierarchical relationship between them, using a hyperbolic embedding space allows us to more readily take advantage of those relationships and improve performance. With that, I'd like to acknowledge the funding for this research, as well as the support from Ning Lab and the lab mates there and collaborators. My contact information is here, and this has only been a small part of the research that we do at Ning Lab. Although my work is mostly focused on multimodal fusion and electronic health record data, there's a lot of other work that goes on in Ning Lab related to de novo drug generation and drug discovery. So if you're interested in reading more about that, you can visit the lab website link here or scan the QR code. Thank you.
Thank you, Ben. So this is really informative and interesting work. So I'm going to start fielding questions from the Q&A boards. What about 2D and even 3D dynamic imaging, such as echo, US2AI, or FMI, etc.? So there must be more difficult to choose, label, and analyze. So what are your thoughts on this?
So my understanding of the question is the difference between 2D versus 3D imaging.
Yeah.
Yes, so I don't think I actually mentioned the modalities that we were looking at for the neuroimaging fusion, uh, the T1 MRI, FLAIR, and the different PET types were all 3D modalities. I visualized them as 2D slices of those 3D modalities. But the difference here is really just going to be in the encoders. So we use 3D CNNs to process our modalities there and extract the features from the raw images. If we were using a 2D modality, you would use a 2D CNN, for example. Um, I don't think that it would be too much more difficult to uh, use 3D modalities over 2D modalities for this reason.
Okay. And then so I think one of the key design choices is moving from a shared sparse mixture of experts router to independent routers for each modality. So can you explain the intuition for why that architectural change should help specifically in the missing modality setting?
hmm Yes, so maybe I should go back to that slide in order to have the visual. Um, so we had the architecture here. So we replaced the single router with modality independent routers for the expected case where we have only one modality available. In this case, we want to have as good of a routing through the mixture of experts as possible. If we're using a single router design, then this router must cater to each of the modalities that the model can accept, and thus the routing strategy may not be as individualized for the one modality that we have available in the case. So by having the independent modality routers, our routing can always be specialized for each modality so that if we have just one available, we're using the best strategy possible.
So do you think that the modality-specific routing improve the robustness mainly through reducing interference across modalities or because it lets the model learn better expert specialization?
It's probably a little bit of both. I'd say that the main performance improvements are coming from, again, that ability to have the specialized routing procedure for each modality. Because in the case that we have just one modality available, we want to be using the best routing strategy.
Cool. So let's shift the gear a little bit and then talking about real world deployment. So imagine in real clinical settings, of course, the missing modalities are rarely random, right? So some scans are missing because of the cost or access or workflow concerns or patient condition. And so how do you think about the differences between the missing by design in modeling versus missing in practice in deployment?
hmm Yeah, this is a very good point. Unfortunately, when data is missing, it's missing, and it's most likely not missing at random. There is a reason for why it's missing, but our approach around that really is going to be the same no matter what. And the leading approach now is to make the model work. We need to have some placeholder for the missing data. And that's why we do use imputation methods here in our method and in FlexMLE. We still do use imputation. But again, the key issue with just using imputation alone is that we now are processing the data as if all of it's real. We need to provide the flexibility to differentially process based on which modalities we deem to be reliable because they're actually observed versus which ones may be less reliable.
Okay, yeah, so I think that's a good perspective. Okay, so I'm seeing actually no further questions from the Q&A board, and I want to take this opportunity to thank you, Ben, again for this very informative talk. And then you definitely achieved a lot when building the models and then helping thinking about the deployment and in real clinical settings, of course, will position the model to be even more impactful and clinically meaningful. So with that, I want to thank you again, Ben, for this great talk, and also wanted to remind the audience that in a couple weeks, that we're going to have colleagues from Harvard Medical School to talk about their development and deployment efforts. So stay tuned. Until next time, and stay safe and healthy, everyone. Take care.
Thank you.
Bye.